Good afternoon, everybody, and welcome to the Advancing Excellence in Long-Term Care Collaborative's first Spotlight series. Today we are focused on special needs plans, and we have some national experts on the line with us to describe how special needs plans, which is a Medicare Advantage program, can work and do work in our post-acute long-term care setting. I'm Chris Laxton, immediate past chair of Advancing Excellence and current executive director of AMDA, the Society for Post-Acute and Long-Term Care Medicine. First up today is Dr. Cheryl Phillips, who is the president and CEO of the Special Needs Plan Alliance, a national leadership association for special needs and Medicare Medicaid plans serving vulnerable adults. Prior to the SNP Alliance, she was Senior VP for Public Policy and Health Services at Leading Age, and she has also served as co-chair of our Advancing Excellence in Long-Term Care Collaborative. Dr. Phillips is a past president of the American Geriatric Society and of AMDA, the Society for Post-Acute and Long-Term Care Medicine. She continues to serve on multiple technical advisory groups for chronic care, nursing home quality, and home and community-based services, and has provided numerous testimonies to the United States Congress. Following Dr. Phillips, we'll have Dr. Ronald Shumacher, who serves as Chief Medical Officer for Optum Senior Community Care and National Medical Director for Optum Home and Community Care, an integrated community-based care solution for high-risk, chronically ill, and medically complex populations across multiple settings. He previously served as Executive Director and Senior Medical Director of Forever Care of the Mid-Atlantic and Medical Director and Vice President for Clinical Delivery for United Healthcare. With Dr. Shumacher is Jamie Babcock, who is advanced nurse practitioner, Vice President for Clinical Field Operations for Optum Senior Community Care. Jamie is a board-certified adult nurse practitioner, earning her master's degree from Ball State University, and has been in the healthcare industry for over 16 years, and with Optum United Healthcare Group for the last 10. Jamie has held multiple roles from field-based patient-facing positions to senior leadership. So without further ado, Cheryl, I'm going to hand this over to you for some interesting information.
Well, thank you, Chris, and thank you for including me. It's wonderful to be talking back to the Advancing Excellence family. I miss my days with the meetings and the amazing work that all of you are doing and the voice that you have for driving and improving excellence in America's nursing homes. So special needs plans, we'll talk a little bit about them. And Chris gave an overview of the Special Needs Plan Alliance. And we focus on both special needs plans and Medicare, Medicaid plans, which are a demonstration model that are actually phasing out in 2025. So special needs plans, what are they? I suspect some of you have heard about SNPs. They have actually been around. They were made, they were authorized in 2003. They were first enrolling individuals in 2006, and they were actually made permanent in 2018. And they're presently available in 48 states and the District of Columbia. So they are a subtype of Medicare Advantage. So many of you know Medicare Advantage as Medicare HMO, but they can be either Medicare HMOs or preferred provider organizations, but they're a subtype of Medicare Advantage. Right now, they enroll, SNPs in general, enroll about 5.5 million individuals. The vast majority of those, over 4 million, are in what we call dually eligible SNPs or D-SNPs. And because CMS loves acronyms and loves categories, not only is there the coordination organization of D-SNPs, but underneath D-SNPs, there are two subtypes, highly integrated or HIDE SNPs and fully integrated or FIDE SNPs. What's important to know about the FIDE SNPs is that by statute, they must include 180 days of nursing home benefit. So that becomes important in some of the states where FIDE SNPs currently have enrolled individuals, and I think there's presently 12 states that have FIDE-SNPs. Some of them require a nursing home level of care in order to be enrolled in a FIDE-SNP, others do not. So it varies by the state Medicaid structure. And then there are the institutional SNPs and institutional equivalent SNPs that we'll be talking the most about. And then there's also the chronic condition or C-SNPs. These are 17 condition categories that CMS has said are either potentially or actively life-threatening. They carry a great burden. So things like cancer diagnoses or serious heart disease or advanced lung disease, all of those are categories of C-SNPs. And each of them has, as you can imagine, an overlay with the populations that we're talking about in post-acute and long-term care. So in getting kind of a big picture view, let's look at enrollment, benefits, and payment for special needs plans. So only people who are eligible for Medicare, and they must have Medicare Part A and B, can be enrolled in a special needs plan. They must meet one of those distinctive categories. Either they're dually eligible for Medicare and Medicaid, or they are at an institutional level of care, which is determined by the state, or they have one of the chronic condition criteria. That's what makes them eligible to be in a special need plan. So they need to be eligible for Medicare and meet the qualifying criteria. And when they reach that qualifying criteria, they are allowed to have special enrollment periods. And I know these are lots of acronyms, but special enrollment periods means that they can enroll into these plans throughout the year. Those of you who are familiar with Medicare, I'm getting very intimately familiar with it since I've turned 65. And I know that I have a particular time frame in order to enroll. However, under these special needs plans, when you qualify, you can enroll throughout the year. Special needs plans have to provide all Medicare covered services. They also must provide Part D or the drug coverage. But what is unique about special needs plans is that they can tailor their benefits, their provider choices, their drug formularies, really how the scope of the plan serves the population that they are serving. And that is defined through their model of care. So the model of care says, who are we taking care of? How are we taking care of them? What is our network? How do we train our team? There's all these elements to the model of care, and that has to be approved by the NCQA, the National Center for Quality Assurance, that then reports it up to CMS. So the models of care have to be submitted and approved. How do payments work? One of the assumptions is that I-SNPs must have extra money, or any of the special needs plans will have extra money. They actually don't. They get a risk adjusted payment. So based on the chronic conditions, I think those of you who've been following the press and the news lately know there's a lot going on with the advanced payment notice and a lot in the news about Medicare Advantage plans looking for codes, if you will. But special needs plans actually serve these high risk, high needs individuals, and their payment is adjusted by their hierarchical condition codes, or HCCs. But there's, other than the additional payment for dual eligibility, which is an adjustment in, if you will, for low income status, there's no additional payment for special needs plans. They're paid just like any other Medicare Advantage plan, but they're able to target enrollment, target services, target their network, and target the kinds of services delivered under their model of care to the population that they have identified. So let's talk about institutional special needs plans, because that probably has the greatest impact in the focus that we have in advancing excellence. It is true that any of the special needs plans, for instance, a dually eligible special needs plan or a D-SNP can have folks in nursing homes. And we already talked about FIDE SNPs having 180 days of nursing home benefit. But what's been happening for the last many years is a focus on the institutional special needs plans, those who are at an institutional level of care for at least 90 days. It's important to note that you don't have to be in the nursing home. There are also IE or institutional equivalent special needs plans, specifically for those who are institutionally level of care, but living in the community, most commonly assisted living or senior living communities. And plans can even offer a hybrid of I-SNP and IE SNPs. I and IE SNPs can either be plan sponsored or provider sponsored. So I'll give you a little kind of the world of Cheryl according to that. So a lot of nursing home providers have disliked managed care intensely. Managed care plans often paid them less. They were delayed in their paying. There were a lot of denials. And so a bunch of providers said, we hate managed care. Let's be one. What could go wrong? There's both the good and the bad to all of this. The plan-sponsored I-SNPs have been around the longest, and certainly the leader in that is United Optum, and we'll be hearing from Ron and Jamie about how that's structured. But the provider-sponsored is typically done either through a very large provider group that has the capacity to set up a Medicare Advantage plan, which is no easy task. This is not like one standalone nursing home with 150 residents can say, I'm going to be an I-SNP, or a senior living community that has 80 residents, I'm going to be an I-SNP. Because you have to be able to set up a Medicare Advantage plan. You have to have all the compliance elements. You have to have the capacity to accept risk, because you are now the Medicare plan for these individuals. An I-SNP, even though the majority of those in the nursing home side are in fact dually eligible, because when you think about it, most people who are long-stay nursing home residents, we know that Medicaid is the majority payer for long-stay nursing home residents on the board and care side. The I-SNP is not required to have any coordination on the Medicaid side or with the state, because remember, the I-SNP is the Medicare benefit. It's the entire Medicare benefit. It covers all the Medicare required services, but it is not by nature and its design part of the Medicaid benefit. Dually eligible SNPs coordinate on the Medicaid side. I-SNPs are the Medicare benefit. But there's increasing discussion that's happening in multiple states of how I-SNPs and IE SNPs might coordinate with the states on some of the dual benefit stuff. But if folks have questions about that, please let me know, because I don't want to get too much in the weeds. So let's look at enrollment and numbers. I-SNPs have had a particular challenge in the last several years, and I think every one of us who has any relationship with nursing homes understands the impact that COVID-19 had, not only on individuals residing in the nursing homes and the workforce, but also on people wanting to come to nursing homes and enrollment in I-SNPs. We're just now starting to see that turn around from the low point in 2021. So the yellow line is the number of plans, and the green bar is the enrollment, which right now, actually in 2023, is just now back over 100,000. Remember, D-SNPs have almost 4.5 million. So I-SNPs are certainly the little cousin to D-SNPs, in part because of the nursing home level of care requirement. Who sponsors I and IE SNPs? Remember, I said it can be providers, as in nursing home providers, or plans. And very often providers, the nursing home providers, have actually gotten together and utilized management service organizations like Ally Align that you see on this list. So they do the heavy lifting for setting up the health plan and for all of the coordination and compliance issues on the health plan side. But this gives you, so United is the United Optum that we'll be hearing from Dr. Shumacher and Jamie. And then these are the other larger providers. And then under other are a whole lot of smaller plans. So there are a lot of smaller health plans, even some regional nonprofit plans that have I-SNPs. Thinking of SCAN, Elder Plan, Metropolitan Jewish. There's a number of like smaller plans, but then there's also a number of smaller providers. So for instance, Pruitt has an I-SNP within their nursing home chain. So this is a breakout of who has I-SNPs and who's sponsoring I-SNPs. So let's pause a little bit because this is all good and fine, wonderful, but I like to think about the new way of thinking and the new challenges that I-SNPs can bring into post-acute and long-term care. Because the plan now assumes risk for all Medicare costs, there's a new, there's a partnership, a strategy, and we'll talk a little bit about that in my next slide. But there's an engagement that needs to happen. It's not just the Medicare Advantage plan off in some box somewhere, and it's not just the nursing home doing what the nursing home does for their residents, but there actually needs to be a collaboration and partnership. And it also requires an on-site presence of caregivers and providers, particularly nurse practitioners and PAs, and we'll hear more about that from the Optum model. But it requires a new strategy and new thinking. And I will also offer that there is a flurry of Medicare Advantage looking at long-term care residents, because when you think about it, over half of Medicare eligible individuals now are already in managed care. Right now, the majority of Medicare individuals in nursing homes are still fee-for-service when you look across the country. So it becomes kind of the last fee-for-service cohort. So Medicare Advantage is significantly looking at ways to partner with nursing homes, and I-SNPs become the best vehicle to make that happen. But I will push that clinical leadership are absolutely essential. This isn't just a business model. This needs to be a partnership for clinical delivery. So my last slide, and I'll spend a little bit of time on this before we talk about the Optum model, is driving change in long-term care through the 5 C's. We can't just plop an I-SNP into a nursing home and say good luck, because there are so many required new strategies that have to be in place to drive quality. First of all, compliance. Nursing homes often don't understand the rules of the health plan. And frankly, the health plans really don't understand the compliance and regulatory rules of the nursing home. So there becomes a language intersection that needs to happen. I think it starts with stars. We all know about the nursing home stars. Well, the MA plans, I-SNPs have their own stars, and they're not at all coherent with the nursing home stars. And so we can get staff very confused when we start talking about things we need to do to improve our stars. And staff are like, well, which our Milky Way, which stars are we talking about here? Model of care and health risk appraisals are also new concepts for the nursing home side. They are done by the health plan, but there needs to be an intersection with the nursing home providers. And health risk appraisals are very different than the required quarterly assessments that nursing homes need to do for MDS. Competency. We talk a lot about this for quality in nursing homes in general, but it becomes a heightened focus when you have an I-SNP. Do your clinical teams have the ability to identify and manage acute changes of condition? Because remember, under an I-SNP, there's the opportunity to skill and treat in place. when it's appropriate to do so and not send the person to the acute care hospital? Do your teams have competencies in palliative care, symptom management, and good end-of-life care? Or are they just relying on the emergency room for symptom management? Again, a critical overlay of the I-SNP and the nursing home. Capacity, do you have the resources to do all of these things? Do you have the right staff with the right skills? Do you have adequate staff? Do you have adequate staff during all shifts? If you are challenged as a nursing home with adequate staff, putting an I-SNP in place, unless you have a relationship with the I-SNP for additional staff, doesn't solve your problems. Do you have the capacity to take care of the needs of the resident across the continuum? The culture, boy, that's such an important one. And those of you on the clinical side, whether DON staff, CNAs, medical directors, nurse practitioners, you know that marriage of the importance of culture. The culture of, if it's 4 o'clock on a Friday, I remember being a medical director in a nursing home, and the policy was if it was 4 o'clock on Friday and somebody wasn't looking very good, they got sent to the emergency room because we just didn't want to take care of a sick person over the weekend because we didn't have the staff to take care of them. That was in the 80s. Life has changed. Do you have the culture that says, how do we manage people through changes of condition? How do we manage people through shared learning or shared problem solving? Do we have a person-centered focus of care, which gets into our next and the 5th C? How do we integrate individual goals into plans of care? How do residents express their wishes and preferences? Are they carried through into the care plan? So as you can see, when an I-SNP fully partners with the nursing home and fully embraces these 5 C's of compliance, competency, capacity, culture, and person-centered care, they actually have the ability to improve the quality of care, not only for those enrolled in the I-SNP health plan, but frankly, for all of the residents in the nursing home and senior community. So with that, I'm going to transfer now to Ron and Jamie, who will talk about how they put these 5 C's into practice on a day-to-day basis. Thank you.
So first of all, that was just a fantastic description of special needs plans. Dr. Phillips really did a great job explaining all that. And I want everyone to know that Jamie and I both sort of live and work within that clinical overlay area that Dr. Phillips talked about. We are sort of the link between the clinical delivery system and the health plan, which the I-SNP is. It's a health plan. And that is what we've kind of dedicated our careers to over time. So now that you know all about what special needs plans are, I just want to tell you a little bit about our story at Optum, because our organization didn't suddenly just materialize in 2006 when SNPs were allowed to start enrolling members. And in fact, we've been providing this type of clinical care and care coordination services in nursing homes for many years. Many of you may remember the name Evercare, and that was our precursor organization. Evercare was built organically within United Health Group. It was started by 2 very savvy nurse practitioners who had significant concerns about the way care was being provided in the nursing home setting. They questioned the frequent unnecessary interventions, the repeated emergency department and hospital transfers, the lack of communication that took place in nursing homes, and they pointed out especially that there was this senseless kind of 3-day hospital stay requirement and a lot of fragmentation in the way care was delivered in that setting. And so they launched a clinical program all the way back in 1987, and that model, or at least the foundation of that model, is largely still intact today. it wasn't until 1995 that the path was really cleared to launch this clinical model in additional states other than just in the Twin Cities in Minnesota where they started the program. So in 1995, a multi-state CMS demonstration model was launched. And that demonstration was evaluated by the renowned geriatric researcher, Dr. Robert Kane, and his colleagues from the University of Minnesota. They were commissioned by CMS to evaluate the clinical program, and that culminated in a series of publications in the Journal of the American Geriatric Society and other peer-reviewed journals. I'll give you just some highlights of some of those studies because they're from the early 2000s, so they're somewhat aged now, but the findings and the data in those studies is really very compelling. In 2000, there was an article called The Implementation of the Evercare Demonstration Project, and there was data in that article in the Journal of the American Geriatric Society that supported the fact that more attentive primary care can reduce subsequent expenditure on healthcare. In 2001, an article came out by Dr. Kane and his colleagues again on how Evercare NPs spend their time. And one of the most significant conclusions from that was that much of the time, in addition to just direct care and care coordination, was actually spent on communication with patients and their families or responsible parties. In 2003, an article called The Effect of Evercare on Hospital Use, the predominant finding there was that Evercare prevented hospitalizations and hospitalizable events. Evercare also allowed cases to be managed more cost effectively without compromising quality. And then in 2004, the effect of an innovative Medicare managed care program on quality of care for nursing home residents, showing that nurse practitioners play a very effective role in managing nursing home residents. So these were really important findings, and they sort of paved the way for this Evercare program to become an I-SNP when that I-SNP legislation was passed. And ultimately, Evercare's care delivery system was moved into Optum. And Optum is the health services company under United Health Group. And the program was rebranded as Optum in about 2010. The health plan itself, so not the clinical delivery system, but the actual health plan remained in United Healthcare, which is United Health Group's health benefits company. And that plan is now known as the United Healthcare Nursing Home Plan. So as you can see on the slide, today we're operating in 33 states. We're serving approximately 58,000 I-SNP members. And that makes it the largest I-SNP in the country. And keep in mind, these are all long-term care residents. Their home is the nursing home. So they have to have Medicare Part A and B. And just, to give you some insight into how the financial model works. So the health plan, United Healthcare, receives a per member per month premium payment from CMS. And that payment is risk adjusted according to Medicare's hierarchical condition category system. And then Optum gets paid a percentage of those dollars to provide the care and the care coordination services, as well as a number of other functions, such as the direct sale of the insurance product to the consumer in the nursing home. Typically, it's their family who enrolls them in the program because many of them are unable to make that decision or to make their own decisions regarding their health care. So that just gives you a little bit of an overview as to how Optum's I-SNP came about and how we operate. But at this point, I'm going to turn it over to Jamie to talk a little bit more specifically about our clinical model itself and what that looks like. Jamie?
So as we look a little bit more at our institutional plan, The clinical care delivery model sits at our core. And I thought, Cheryl, you framed it up perfectly of how these all the components have to come together to make an I-SNP successful. And we deploy a multidisciplinary care team to the SNFs that we partner with and the members that we serve. And the care team really prioritizes collaborating with the existing care team that is in the nursing home, collaborating with the PCPs and our medical directors that are in the nursing home. And our care team really comes in to provide an additional layer of care. We don't replace. And it is the expectation of our teams that we come in and we work collaboratively with the existing care teams just to elevate the level of care that those members are getting. If we break down our care model a little bit more, we deploy a multidisciplinary care team, and it is anchored by our nurse practitioners or physician's assistants, and we refer to them as APCs or advanced practice clinicians. And they are really on point to manage chronic disease management, acute disease management, advanced care planning. They really are the quarterback of our team. And surrounding our APC, we put in a couple support roles. One of those being an RN. They help to do follow-up visits. They help with medication management, PT/OT screenings, and just general care coordination at the direction of the APC. Additionally, we put a care navigator in place. This is a non-licensed administrative person that is in the field, and they help our APCs and RNs by backfilling charts. They may do updates for us, calling it specialists, the referral notes. But additionally, they help serve our facilities too. They will make appointments for them, and they will set up transportation, anything to help support that care team so everyone can practice at the top of their licensure. Additionally, the last thing I want to touch on is around our risk levels. So we risk stratify all of our members when they come onto our program, and the risk level is based on their chronic conditions and their past medical history. So based on that risk stratification, we will deploy various intensities of our care model, meaning our highest risk members or the most fragile will have more visits in order to manage their care and their conditions. While our lower risk members, they have fewer visits. Much like you and I, we may go to our physician once a year. However, someone with a chronic disease like hypertension, they may be there every 3 months or once a quarter. We do the same thing with our members as well. However, regardless of their risk level, all members are seen whenever they're needed to manage those acute conditions or acute changes in their current condition. Maybe the family has a question for us. Maybe the member has a question for us. We can pause and take time out of our day to pivot. And I think that's the beauty of value-based care, is we can alter and shift our day to accommodate the needs of our members and spend time where we need to spend it. So just like you and I, our members may move up and down in a risk level, according to life events, progression of diseases, or acuity, and the team will readily assess members on a routine basis to ensure they are in the appropriate risk level to get the right care by the right member of our team. So moving forward, as we look at some of our clinical outcomes, obviously clinical outcomes is a key KPI for us. And we have several levers that we're always looking to pull so we can manage and drive to our top tier clinical outcome. So I share this slide, not for anyone to read all the content on it. I will walk through a lot of it, but I want to highlight a key priority for us, which is advanced care planning. And we were really proud to present this poster at Gapna last year to highlight the work around advanced care planning and disseminate some of the best practices that we have seen and knowledge so that other populations can benefit from it as well. And I think something that makes our model so special and unique is the approach we take around advanced care planning. And you'll note that this is not about code status, it's not about advanced directives, and you actually won't find those words in the presentation. It's more about learning about the member, learning the why behind our decisions that the members make for themselves or an RP makes for themselves. It's about ensuring we have a total understanding of the member and the family before we initiate a treatment plan. Understanding what drives the decision making allows us to provide goal concordant care. And while we may not always align, we recognize our job is to meet our members where they are, or meet their family and RPs where they are. So we review advanced care planning on a routine basis with our members and their families to ensure we're always aligned with them. It can be one small life event, one fall, one illness that can completely change someone's wishes or perceptions. And we take a lot of pride in ensuring we understand exactly what our members' wishes are for treatment. And this approach has proven, time and time again, that it allows people the autonomy to drive their healthcare decisions by being informed on disease trajectories, being informed on treatment options available before there's a decline or before there's an exacerbation. So we've spent a lot of time here, and this has been a core of our model and what's helped make us successful over the years. So I'm happy to share it with you today. I'm going to pass it back to Ron just to walk through a few other clinical outcomes that we strive towards.
Yeah, thank you, Jamie. So another activity that we at Optum are able to engage in a very robust way is medication optimization and management. So I just want to share a couple of examples of that. This also is from a poster presentation. This was displayed earlier this month at the PALTC 23 conference, the AMDA annual symposium. The concept here, and I know this is hard to see, but we were leveraging our advanced practice providers to review and take appropriate action related to overuse of medication. So the way this was accomplished was through a comprehensive education and training effort that was focused and targeted on 3 medication classes. And it was algorithm-based in order to drive both clarity and action. The thinking was that if we could focus on a very finite number of medication classes, we wouldn't overwhelm our clinicians, as opposed to just open season and taking this all medication, deprescribing approach. So this approach actually yielded very impressive results, particularly when you compare it with most deprescribing initiatives that we've seen in the literature. And as you can see here, in each category of medication, so it was anticholinergic bladder agents, proton pump inhibitors, and dementia medications, there was a significant percentage of discontinuation of the meds. It was actually 51% of the anticholinergic bladder agents, 35% of the proton pump inhibitors. And the dementia medications were looked at through 2 different lenses. There were patients who were prescribed dementia medications despite being functionally dependent, and patients who were prescribed dementia medications despite expressing a preference for comfort care only. And they had 36 and 27% discontinuation rates, respectively. You'll also note that a significant number of patients in all the categories had dose reductions or change to a more appropriate medication in the same class. So all told, more than half the patients on the bladder agents or the PPIs had either a discontinuation or a dose reduction. So this is an approach that we're going to replicate with other classes of medications. It's also aligned very closely with the CMS quality measures and the nursing home star ratings. Another example on the next slide of work that we do on behalf of our members is around medication adherence. This is also a very visible quality measure in the nursing home population, and it's known to be associated with better clinical outcomes and reduced mortality. So by developing a process for our advanced practice providers to collaborate with our employed pharmacy team, we've been able to ensure that medications are being appropriately refilled in a timely manner or discontinued if they're not adding clinical value or causing adverse reactions. And CMS uses those timely refills as a proxy to indicate that medications are being taken as directed. So you can see that we have very high rates of adherence, over 90%, which is no small feat in the nursing home setting where medications often get held for various reasons. And then the last outcome I want to highlight on the last slide is our ability as an I-SNP to impact hospital, emergency department, and skilled utilization in a positive direction. And this is just as Dr. Kane demonstrated in the early Evercare studies, but there's a much more recent study that was published in the American Journal of Managed Care in the fall of 2019. That's referenced at the bottom of this slide. But researchers from Harvard Medical School found that even when they adjusted for demographic differences using propensity matching, the I-SNP members had 38% fewer hospitalizations, 51% lower emergency department use, 45% lower readmission rates compared to the fee-for-service Medicare group. The rate of skilled nursing facility utilization or skilled utilization was 112% higher in the I-SNP group. So this demonstrates that, this type of clinical delivery model can successfully shift care to a less costly clinical setting. The study concluded that if traditional Medicare beneficiaries in skilled nursing facilities exhibited similar patterns of utilization, it could result in a decrease of more than $1 billion in spending on ED and inpatient services annually. So that was pretty impressive. And I think, is that the last slide? Oh, we have a couple things on how we responded to the pandemic. So Jamie, I'll let you talk about that.
All right, thanks, Ron. So yeah, throughout the pandemic, we saw, I think, so many entities, around the country that really expanded their capabilities to support one another. And within Optum, we did the same thing. And there was an article published in Skilled Nursing News in 2020 that from Sabre, one of our partners, that I thought really demonstrated how integrated our teams are and how integrated successful I-SNPs are. And with their SNP partners, they said, it's not that we had to build a collaboration to face this. It's the strong collaboration that we had leading up to this that allowed us to be so successful together. And together with and for our SNP partners, we were able to provide PPE equipment, meals, snacks for the SNP staff. As we saw some of them not going home at night. We brought in non-clinical staff like our client management, our sales agents, to help pass trays and change beds and empty trash cans, whatever was needed. And additionally, we brought in staff education to the SNFs. We are fortunate to have an infectious disease physician on our staff that we worked hand in hand with and with our teams to ensure that we had the most up-to-date protocols around PPE and treatments and spacing guidance and everything that was coming, seemed like every day updates. And we were able to relay that back to our nursing home partners and give them the education to ease their anxiety as well. And then lastly, I think the best part, we were so proud to partner with Optum Rx to mobilize the use of monoclonal antibodies. This was kind of a brand new venture. It was a brand new innovation that really allowed us to bring a top line therapy treatment to our members in the SNFs. And they may not have had access to that otherwise, right? So we dedicated our staff to giving the infusions, monitoring them post-transfusion, the SNF, as we didn't want to burden that staff anymore. And we were able to give thousands of doses to prevent the progression of COVID and therefore reducing hospitalization rates and overall cost of care, all while keeping our members in their home with the staff they know. So COVID really was an incredible opportunity to collaborate with our partners and demonstrate just how well we can all work together and how integrated we are with our partners. And as we came out of COVID, I think it's only made a lot of our partnerships stronger with those that we work with. So as we close, Ron, I will hand it back to you.
Thank you, Jamie. And I would just conclude with the following. I think what we've shown you here today is that institutional special needs plans are one very important and very viable model that can improve access to on-site care for long-term nursing home residents. And as we've shown you, our I-SNP within Optum and United Healthcare is patient-centered, it's goal concordant, it provides top-tier chronic disease management and care at the end of life. It allows us to focus on initiatives to improve care and outcomes, such as medication optimization and medication adherence. It reduces unnecessary medical costs. And ultimately, it truly achieves the quadruple aim. And it's able to do that because we're able to operate within the context of a value-based payment model as opposed to a pure fee-for-service model, which traditionally is what you see provided in the nursing home setting. So I hope this gives everybody an appreciation for special needs plans and specifically for an I-SNP operating in post-acute and or long-term care. Thank you all.
Great. Thank you all so much. I appreciate it. Ron, Jamie, Cheryl, that was an excellent presentation about what sounds like an extremely effective model. So I appreciate it. We do have a couple of questions. The first one actually from Dr. Sabine von Price-Friedman, who, Ron, you may know, is one of the leaders in our own drive to deprescribe medication optimization program. The question is, often adherence with medications are not concordant with goals of care, and this is problematic for adherence to Optum standards. Can this standard be modified according to disease status?
I can take that. I think, a very good question, and we've asked that many times ourselves. The medication adherence measure is a measure that applies across all Medicare Advantage plans. That's a CMS measure that came from, it's one of the pharmacy measures. And so we're trying to comply with that measure in the best way that we can. And sometimes what that means is that a medication that somebody has been prescribed may not be the right medication for them. It may not be needed at all, may not be concordant with their goals of care. And so our first priority is to look into that and discontinue medications when they really aren't adding value. However, when it's clear that a medication is adding value and it's helping to manage somebody's chronic disease, it is our obligation to make sure that the patient is getting those medications and taking those medications routinely. And if we're seeing that medications aren't being refilled each month, or there's still 20 pills left after 30 days of use, presumed use, that's problematic too. And so there's a sweet spot in there somewhere where we want to make sure people are on the right and appropriate medications, and when they are, that they're receiving those medications consistently.
Ron, I'd like to add to that because, Sabine, yes, you guys all know this is a NCQA standard for quality and it gets reported to CMS, but there are exclusions for populations, for frailty, for end of life. And I think sometimes clinicians don't document those exclusions, which then can be used by the plan to say, hey, this is nuts. We don't need this person on a statin anymore when it's no longer clinically appropriate.
Yeah, great point.
Great, terrific. Another question from Sabine. My medical directors are concerned that they have spent non-billable time with Optum NPs to review care. What can be billed for the supervision?
Well, so we do pay physicians in a lot of different ways. So we have contractual arrangements with some physicians where they can get reimbursed for more than just the codes that they submit. We also pay for some things that may not be paid for under Medicare. But this is something that we also believe needs more attention, because we know that in order to be successful, we're not taking the place of the physician. We need to partner and collaborate with the physician. So we're looking for creative ways to align with physicians around that. And it's an excellent question, and we certainly want to be attentive to that and understand that we are asking a little more of the physicians in terms of collaborating with our advanced practice providers, and we sometimes take more of their time. We're also asking them to see the patients frequently. I mean, we're placing no limits on them in terms of how often they see their patients, and they can get reimbursed for that.
Terrific. Thank you. I don't see any other questions in the Q&A, so I think what I'd like to do at the last minute here is to ask Penny to wrap us up and talk about the rest of the Spotlight series.
Well, thank you so much, Chris, and thanks to you, Cheryl and Jamie and Ron, for this wonderful presentation. We got that in the Q&A too. What a wonderful presentation it was, especially for a complex topic. So thank you so much. And for all of those out there, we're actually continuing the Spotlight series throughout the year this year. Advancing Excellence really wanted to give to you information that we think was relevant, that you would need, and a great place for you to find that. So we're doing a Spotlight series throughout the year, and that continues in June with our Spotlight on Leadership. And then in July or August, we're going to have a spotlight on clinical leadership. We think this is so relevant to our current situation of workforce challenges. So please be on the lookout for that. And if you'd like to learn more about Advancing Excellence, please go to our website, advancingexcellence.org. If you'd like to become a member, you can reach out to us through that, or you can email any one of us on the executive committee, and that's on the website as well. So we want to thank you so much for being here today, and we want you to join us for our next Spotlight Series webinars as well. So thank you, everyone, and thanks once again to Chris and Cheryl and Jamie and Ron. We really appreciate it.
Thank you for having us.
Thank you all.
Bye, everyone.
Bye, everyone.
Thank you.
Thank
Have
you.
a good rest of the day.
Thanks all. Bye-bye now.